2, 3, go.
Hi, my name is Ashlyn Ayler, and I'm a student at William Carey University. Today, I'm going to be lecturing on Introduction to Nursing Documentation. Our objectives are as follows. At the completion of this lecture, the student should be able to explain the importance of nursing documentation, identify barriers of nursing documentation, describe how auditing can improve nursing documentation, describe the legal aspects of nursing documentation, and critique nursing documentation. The goal here is that the student will obtain a baseline knowledge of the importance of documenting. By now, you have been in nursing school for a semester or two, and at some point, you may have heard this mantra: if it wasn't documenting, it didn't happen. What does the word documentation mean to you?
It means that I must make sure that I paint a clear picture of what happened during my shift.
Thank you. Documentation can be both subjective and objective. Subjective is what the patient says. Objective is what is observed by the clinician. For example, subjectively, a patient may say, I smoke 2 packs of cigarettes a day, or I drink a case of beer a day. Objective, the nurse may observe vital signs that have been taken: temperature, pulse, respirations, blood pressure, oxygen saturation. All those things the nurse can observe. But I would like to caution you to the concept of pain. Pain is a concept that can be both subjective and objective. Subjectively, pain happens to the patient at the time they say that it's happening, the frequency, the intensity. Whenever the patient says it is what it is, the pain. Objectively, a nurse can observe a patient becoming more restless, vital signs fluctuating. They also can observe a patient's facial grimace for pain. Whenever you're documenting, I encourage all nurses to document the facts. This is an acronym for facts. Make sure that what you're documenting is factual. Make sure that you are getting rid of all opinions. Make sure that you aren't finger pointing. Make sure that you are only documenting the facts. Make sure what you're documenting is accurate. Stay away from approximations if you can. If you're emptying a JP drain, don't give an approximation for the small amount of drainage. Get a measuring cup so that you can be exact with the amount of drainage. And the description. Complete. We document on flow sheets a lot of time in nursing, especially if it's not a free text note. On your flow sheet, try not to leave any blanks or anything open for interpretation. If it's not applicable or does not apply to your patient, make sure that you write that in that column. Timely. Try to make sure that you are documenting in as close to real time as possible. As nurses, we are held by many standards, and it is our duty to make sure that we are familiar with the standards that we are held by. We are held by the documentation standards of the American Nurses Association, the Nurse Practice Act. Whatever state you live in, make sure that you familiarize with your Practice Act is. And if you are a traveling nurse, make sure that you familiarize yourself with the Nurse Practice Act of that state, because those are the standards that you are going to be held by. The Joint Commission is a regulatory body that holds nursing documentation to standards, and the facility or organization that you work for also have standards that you're being held by. Nursing is a very tough job, and there are many barriers to documentation. Disruptions or interruptions is one of the most frequent barriers that nurses report. Nurses are interrupted at the nurses station by family members, doctors, other members of the interdisciplinary care team, and at some point, maybe even their own colleagues are interrupting them. Time constraints. Again, nursing is a very tough job and we have lots of tasks that need to be completed. Sometimes 12 hours just doesn't seem like it's enough tasks to do everything that we need to do. As nurses, we are so focused on caring for the patient that documentation is often left to be an end of shift task. At this point, nurses are power charting or charting at the end of their shift as much as they possibly can chart at one time. Sometimes there's a lack of clear guidance or expectations on what to chart, leaving nurses unsure of what should be charted in a flow sheet or a free text note. That is why it's so important that organizations provide their nursing staff or nurses with a good orientation, providing them with the expectations of what should be charted. And of course, there's always a varying lack of technical skill amongst nurses. When we hear the word audit, we often think that someone is going to catch something that we didn't do correctly. Auditing is a great tool to raise awareness of what should be documenting. Here are some nursing do's and don'ts. Always check your spelling. It can mean the world of difference when reading a note. For example, the nurse walked the patient down to the hall versus the nurse walked the patient down to the hall. The nurse listened to fecal heart tones instead of the nurse listened to fetal heart tones. The patient had a pulse of 64 instead of the patient had a pulse of 64. Chart as close to real time as possible. I cannot stress that enough. Late entry, try to explain why your entry is late, and always verify that you're documenting on the correct patient. Nurses will document in the wrong patient's chart by accident, only to have to post an erroneous note and begin to document the correct information in the correct patient chart. However, we have some don'ts as well. Don't use unapproved abbreviations. Don't alter the medical record for yourself or for your colleague. Don't falsify documentation. Here's a case study. This is an opening shift note. Patient sleeping in bed quietly with eyes closed, alert and oriented, time 3. Respirations even and unlabored with oxygen via nasal cannula at 2 liters per minute. Right antecubital IV, 20 gauge, dressing dry and intact with normal saline infusing at 1,000 cc's per hour. 3+ pitting edema noted to the bilateral lower extremities. Vital signs presently read 102.3, 106, 25, 190 over 64. Patient's wife is at the bedside, states the patient walked to the hall last night and tolerated it well. Let's discuss what's wrong with this opening note. Do you see anything wrong with this note?
Yes, I see several things. They have patients seeping when it should be sleeping.
Correct.
And I'm not sure if that's 21 p.m. or should that be 2 liters. And I'm not sure exactly what race is. And then also patient's Wi-Fi is at the bedside. That's definitely incorrect.
So when I see a note like this, what I think about is a nurse who is rushing and a nurse that doesn't pay attention. And it makes me question the type of care or the quality of care that the patient actually received from that nurse. So here's what's wrong with the note. When I read the note, I read what the nurse was intending to write. PT sleeping, that should have been patient sleeping. Rest, she abbreviated it where she could have wrote respirations. NC, is that North Carolina or is that nasal cannula? At 21 p.m. or is that 2 liters per minute? Race, she intended to say right anticubital IV, DI, dressing dry and intact with NS, normal saline, infusing at 1,000 milliliters per hour, which appears to be more of a bolus than a typical infusion. 3, pulse pending, should have been 3 plus pitting. Edema to the BLT, to the bilateral lower extremity. VS is that vital signs, or Victoria's Secrets. Presently reads all the abnormal vital signs listed. Patient's wife, the nurse wrote Wi-Fi, at the patient's bedside, and the patient walked to the hell last night and tolerated it well. This is the revised case study note. It should have had follow-up and what was done about those abnormal vitals. So, patient sleeping in bed quietly with eyes closed, awake, alert, and oriented, ×3 respirations, even and unlabored, with oxygen in via nasal cannula at 2 liters per minute. Right antecubital IV, 20 gauge, dressing dry and intact, with normal saline infusing at 100 milliliters per hour. 3 plus pitting edema to the bilateral lower extremities. Vital signs presently read 102.3, 106.25, 190/64. Female visitor at bedside stated that the patient walked down the hall last night and tolerated it well. Nurse called the physician and reported the vital signs that were as follows. The physician stated to administer Tylenol to address the fever, clonidine to address the blood pressure, and blood cultures to address the spike in temp. So let's discuss why nursing documentation is so important. It paints the clinical picture. It is used as a communication tool between clinicians. It affects reimbursement, or the bottom line of the hospital. And it helps us to avoid risk and legal ramifications. This is why nursing documentation is important to me. This is a picture of my family. My nursing documentation and my nurse's license is so important. Once you get your license, you want to hold on to it and make sure that you're able to continue to support your family, not to mention the student loans that I've obtained from getting my nursing degree. Are there any questions? These are my references.